So, a very good afternoon to everyone who's joined us today. My name is Dr. Revati Raj, and I'm the Secretary of the ISBMT. And it's a privilege and an honor to present to you the webinar today on this really special day of International Women's Day. So, every year, 8th of March is celebrated as International Women's Day. And this year, the theme is for all women and girls, rights, equality, empowerment. So we are here with an absolute star-studded galaxy of specialists. The mentors of the support group of ISBMT are President Dr. Sashikant Apte and Dr. Tapan Saikia, our senior transplant physician. We are backed up by Dr. Venkatesh Ekbote, Dr. Silky Jain, Ms. Ria, and Ms. Suman, who have really put in a lot of efforts to bring every one of these series together and made it a success. And the people behind the scenes, Rashmi and Jolly of ISBMT, our secretariat, thank you everyone. And to each of you who have joined today. And people may ask, why do we need an International Women's Day? Because there are still issues that we need to sort out about equality, about the issues that women face on a daily basis. And our main aim today is to bring a very niche area that is something that we don't talk about much, but is important, namely fertility before, after, and a long term after transplant. And today we have with us a very special speaker, Dr. Puneet Rana Arora, and she's the founder and director of the Center of Infertility and Assisted Reproduction, CFAR in Gurgaon. Now, Puneet comes with years of experience in the field, dealing with survivors of childhood cancer, and to give the special gift of a little baby in the lives of someone who's had a long fight against difficult diseases is a really a special thing that you do, Dr. Puneet, and looking forward to hearing your talk today.
Thank you. Thank you very much, Dr. Revati, and everybody at ISBMT for thinking about this topic, which you said is rightly said, it's a niche and not very much discussed yet at the present time. So thank you. Can I share my screen?
Yes, ma'am.
Okay. Right. So, so what exactly topic or discussion we're going to have in this series is about fertility. So let's understand what exactly fertility means. Fertility means an ability of a man or a woman to conceive and have children. And infertility means inability or where there is a trouble in conceiving or not getting pregnant. So just I'm going to take you everybody to the basic, how this process of reproduction happens in the human body. So in the female body, there is a uterus, there are 2 fallopian tubes and 2 ovaries. And in the males, there are testicles, which make sperms. And in the female, these are the ovaries, which make eggs. So the eggs and the sperms are important component for any individual or a couple to achieve a pregnancy. They are not only the source of giving a pregnancy to a man or a woman, but also source of hormones, which are very important in the body, not only for reproduction, but also for bone health, for breast health, for maintaining the hair pattern in males. So it does a lot of work besides just giving the reproduction. So when we call as male factor infertility, it means something is not right here in the testicles or the sperms which come out of it. When we talk about female factor infertility, which means there can be an issue with the uterus, the fallopian tubes, or the ovaries. So if we see how this process of fertility or pregnancy formation happens in the body, Uh, the sperm is ejaculated in the vagina. It travels through the uterus, travels through the fallopian tube, and reaches its site of fertilization, which is the distal part of the fallopian tube. And the ovary, which is a source of egg, comes to the distal part as well, and that's where the fertilization happens. So once they fertilize here, the process of development of what we called as an embryo or a pre-baby stage, an embryo development or the growth happens in this fallopian tube only before it comes to the uterus and rests there for the rest of the 9 months. So this is the process of fertilization and formation of pregnancy in a human body, which involves an egg, a sperm, a uterus, a tube, and hence the outcome. Uh, so when does this whole process starts happening? This whole process starts happening after puberty. Now the next question comes, what is puberty? Puberty happens a little differently in males and females. When a child or a girl starts seeing budding of her breasts, or growth of pubic hair, or growth spurt, or when she starts her first period, maybe see a little growth of hair in the underarm, change in the body shape, this is what is puberty. She's going through a pubertal change, which means the reproductive organs, the reproductive hormones are undergoing maturity. In males, it is the growth of the scrotum and testes, change in the voice, growth of pubic hair, lengthening of penis, change in the body shape. So all these changes happens around that time, and that's when a girl or a boy is kind of a starts towards pregnancy and reproductive health. Now, what happens when you undergo a bone marrow transplant? So when you have a bone marrow transplant, you have some therapies before you actually undergo bone marrow transplant, which can be in the form of chemotherapy, radiotherapy, or some monoclonal, clonal or polyclonal antibodies. And this is what start affecting the fertility, which means it starts affecting a woman's egg or a male sperm, or sometimes the uterus and the fallopian tubes. So this is why we are discussing today, because BMT can affect fertility. Sometimes it's not exactly the BMT, it's the therapies which go on before BMT could be the responsible factor. Now, how these affect, just a brief slide upon. I have just kept a cut section of the female ovary here, which has eggs. So it has two compartments, a rapidly growing egg and the eggs which are lying dormant or silent. When you have that, what we called as a conditioning therapy or a radiotherapy before BMT, it mainly affects these growing cells, growing follicles. And what we are left with these kind of a dormant or premature cells, which take around 6 to 9 months before they reach this dominant phase of growth. And hence, you kind of, a lot of you would have noticed that you would have finished your bone marrow transplant and it's been 6 months or 9 months, you have not started, a girl has not started her menstrual cycle. It's just because menstrual cycle is because of these growing follicles. And it takes recovery of 6 to 9 months before a girl or a woman will start having menstrual cycle after her treatment is finished. And so this, I just wanted to show that the maximum number of these eggs are when she's a small girl in girls. And then this egg number starts declining anyway. But if you have a treatment of BMT, like conditioning therapy, this drop can happen beforehand, earlier in the age. Similarly, in males, there are three kinds of cell in the testicles. There are the sperm cells, and there are the supporting cells, Sertoli cells and Leydig cells. A lot of medical terms, but what essentially happens is, like explained, the therapy before bone marrow in the form of chemotherapy, radiotherapy can affect my sperm cells. They can affect my Sertoli cells, they can affect my Leydig cells, and hence bring in a change in the reproductive status of a male. So what can we do to prevent it? If you're having a bone marrow treatment, can we do something to avoid the damage which is being caused by chemotherapy and radiotherapy? Certainly, there are things which we can offer. Some we can offer before you start your conditioning therapy or chemotherapy, radiotherapy. Some things we can look after during when you are having your treatment, and some things once you have finished your treatment. So there is a concept of what we called as freezing the eggs, which is called as oocyte cryopreservation. We can freeze sperms in males, which is called as sperm cryopreservation. We can also freeze a part of the ovary, which is called as ovarian tissue cryopreservation. And then during treatment, if you're having a radiotherapy, we can move ovaries out of the way of the radiotherapy, called as ovarian transposition, or we can give some hormones to protect your ovary. And once you have finished your treatment, then also if we have preserved the ovarian tissue here, we can put back in the female ovary, and then she can retain her eggs and hormones. Or if we can offer IUIs and IVF, which I will discuss. So there are a lot of things which can be talked about and discussed about how to prevent it and what are the options you have once you have frozen, once you've had the treatment of BMT. So the options are embryo freezing. Like I said, embryo is like a pre-baby form or thing, which is formed from a fertilized egg. So when the egg and the sperm get fertilized, what is formed is an embryo. So how this happens inside the body. We do it in vitro, which means outside the body. We take the eggs out, we fertilize them with the sperms, we make embryos, and then we preserve them, we freeze them in minus 220 degrees conditions in liquid nitrogen. So that is one option. If a male, if they are a couple, if they're married, they can undergo embryo freezing. For a boy, male, or if they're not married, a male can undergo just the freezing of his sperms. Semen sample. Semen is the sample which is given by a male. We take it in a pot. They give us the sample. We screen out the sperms from it. We put them in a special freezing media and then freeze it. And then later, once the treatment is finished, they can be used to achieve pregnancy. Then the next is oocyte. Oocyte freezing is egg freezing, which we get from the eggs, ovaries. Now, oocyte, to freeze the oocytes, we need to take these oocytes out. And to take them out, it needs a preparation of 2 weeks at least to grow them with the hormones. So a woman or a female may need injections to grow these eggs for 10 to 12 days before we can take them out. So this is slightly time consuming, unlike the sperm cryopreservation, which can be done in a day or so. For oocyte refreezing, we need at least 2 weeks to freeze these mature eggs and then use them later. Now the latest concept which is coming up is ovarian tissue or ovarian cortex. Basically, it is a part of the ovary. So this is how an ovary looks like in real life. We make them into small slices like this, ovarian tissue, and preserve them. And when a woman or a girl has finished her BMT, then we put these strips back into her ovary or very close to the uterus, and then that becomes a source of her eggs, oocytes, and also the hormones. Similarly, males have testicular tissue, but this is still not as successful and is done only in research settings. But ovarian tissue, ovarian cortex is successful and is being offered now. So what happens if a woman or a male or a girl or doesn't freeze all these before they start their BMT? Then they have an option, obviously, we will discuss later. But let's say if they have finished their BMT and if they have frozen it, they can use these oocytes, frozen oocytes, for what we called as IVF. They can use the sperms for what we called as IUI or IVF. Embryos can be directly put back in the female uterus. Ovarian tissue can also be put back in the female body with a good probability and a good outcome. So just to summarize, this is the summary of what all can be done before a male or a female starts their treatment for BMT. Let's say very important we have to do is there a risk of sperms and oocytes being affected? So that risk calculation is very important. Then we have to see whether it is a pubertal state or a prepubertal state. Because if it is a prepubertal state, there are options become less. The only option in girls in the prepubertal is ovarian tissue cryopreservation. So let's talk about males first. Counseling. Everybody should be discussed about this option, whether they are low risk, high risk, prepubertal. I think it's good to discuss. If they can preserve their sperms, if they can give it by ejaculation, very good. If not, sometimes we put a small needle in the testicles and extract the sperms, which is called as testicular extraction. Testicular tissue, like I said, it is not yet proven and it is not being recommended to use currently, except in research and trials. Hormone suppressions does not work very well in the male. In the females, we can preserve the oocytes, we can preserve the tissue of the ovary, we can put the ovaries away from radiotherapy, which is called as oophoreopexy or ovarian transposition. We can give them hormones. So all these conditions can be offered to them to achieve pregnancy later on. And thank you. Thank you so much for patient hearing. I'll finish here. I know there is a panel after it, and the questions can be taken up in that as well. Thank you.
Thank you so much, Dr. Punit, and for making all of these difficult concepts and telling into a simple manner and really taking us through what happens in a normal person and what are the things that can be done. As you rightly said, today's panel discussion is going to be moderated by Ms. Poonam Bagai. Poonam has been a friend for a very long time, and I think the thing I could say about Poonam is that she's a role model for several people here in our country, abroad, and she is the founder chairman of Can Kids Kids Can, and the philanthropy and the extent of advocacy she does for herself. I don't know what time she does have, but it's amazing. And so many people have benefited by her, the kindness, the caring, and also with policy decision making and how we take things forward in our country. I'm really pleased to have you here today, Poonam, for this panel discussion. We also have our panelists, and these are exceptional women, and I'm really grateful that they've taken their time off on a Saturday to be with us. Ria is one of our own. She's a unique person who does psycho-oncology and works in Narayana Health, Bangalore. Dr. Rachna Seth, again, years of experience dealing with late effects of cancer chemotherapy. And she is a pediatric oncologist at the All India Institute of Medical Sciences in New Delhi. And it's our privilege to have her here today. Dr. Ruchira Mishra is a senior consultant at the BMT unit in MRR Children's Hospital in Thane, Maharashtra, and she also has a special interest in late effects. Thank you, Ruchira, for being here today. And Dr. Jayashree Gopal, who's the director, Diabendo India, Chennai, and she's an endocrinologist who had worked at the Baylor Institute in the US and has an interest in cancer related endocrine work and has helped so many of our thalassemia patients. And it's a joy when they start their puberty and they're going to get married. So many milestones we've had together. And I'll hand the podium over to you, Poonam, for beginning the panel discussion. If anyone has questions in the chat box, we'll take it at the end. Thank you.
Thank you so much, Dr. Revti. It is really a pleasure to be here today on Women's Day. As you said, it's, this is today is a day for reminding ourselves that women are as good and equal to men and empowering women and helping them really to be that equal that they can be in society. But as we all know, having babies, uh, nurturing families is also a very real aspect of being a woman. And so today's topic that you have chosen is really, really important. And I thank ISBMT for picking the topic on this particular day because it is difficult for anybody, actually, both man and woman, to cope with the fact that, okay, I have a treatment to undergo, but will that treatment result in maybe my not being able to have children and a family going forward? So we have a great panel with us today, and if you can put up the names of the panelists again, just briefly. As we said, we have Dr. Ruchira, we have Dr. Rachna, who are pediatric oncologists. We have Dr. Jayashree, who's an endocrinologist. Dr. Puneet, who just spoke to all of us and is a fertility specialist and works with all of us for children with cancer, but works as a fertility specialist for young adults and for all couples who face these issues. And then we have Ria as a psycho-oncologist. And with that, therefore, we'll be able to look at questions to do with all types of counseling that families need or patients who are undergoing BMT need. So with no further ado, let me dive straight into asking questions of the panelists and then circling back to further discussions. Right? As we said, the counseling that we're going to do is around medical counseling, which is psychoeducation, which is imparting the education about fertility and BMT. There's psychological counseling, which is obviously very, very real. There is social counseling. What do I do afterwards? How do I cope and how do I manage my life post BMT? And then there's financial counseling. How can I, and Dr. Puneet talked about, fertility preservation. She talked about fertility treatment. How do I deal with the financial aspects of it? I do know that the financial aspects of it will be talked about in a subsequent session as well. So let's go straight into the questions that we have, more focusing today on the medical and psychosocial questions. The questions we will tackle are issues before BMT, issues during BMT, and issues after BMT. So can we move the slide, please, to the first set of questions? First question is to Dr. Rachna Seth. So, Dr. Seth, when a patient is due to start chemotherapy or radiotherapy, should we give information regarding the impact on fertility at the start of therapy, or should we do it during a visit to the ACT clinic?
So thank you for inviting me, and I'll go straight to the answer of this question, and I hope I'm audible. So this does not pertain to the transplant. This pertains to chemotherapy and radiotherapy when you're starting treatment upfront. So in today's era, as we all are talking, I think our knowledge has really increased, and we would want to keep the families, the patients, quite aware of what we are giving them, what chemotherapy, what radiotherapy, what acute and late effects the child is likely to have. So, in my opinion, we will keep some factors like what is the socioeconomic background of the family, and how old is the child and how distressed the family is. But nevertheless, I would want to consider some portions of it even upfront. But even if we are not able to give all information to the family, I would at least like to discuss this concept within all the treating team so that we are aware, we are very conscious of the fact what therapy we are going to give to the child, and every aspects of therapy are well planned. The family may not understand what Dr. Puneet just mentioned, and we are using these concepts of the family may not know that transposition is going to help the child in a big way, and these are now available modalities even in government setups. So Poonam, this is not, it's become a routine with us that we know that, for example, if a child has Hodgkin's lymphoma and you know that this node and it has a bulky disease, you know he's going to get radiation. So you bring your pediatric surgeons well into the picture, well in advance to when you're going to give radiotherapy, you know what you're going to give. chemotherapy, plan just a simple transposition before, so that the gonads are saved. And this is from the effects of radiation. So this is a very small measure which you can really do upfront. And but then the treating team, all the people who are treating the child need to be aware. So I would feel that we all need to be sensitized that such interventions can take care and of the fertility or reproductive dysfunction that could come up later in life. So I would say that our understanding, sensitization, and if possible, to whatever extent we can impart this information to the child or particularly the adolescent and the family, I like to go
Correct. Thank you.
with the answer.
Thank you, Dr. Rachna. And I think what you said for this in the course of upfront treatment would apply also for BMTs. That even if there is a BMT, you would do likewise.
Exactly.
You would do your best to actually inform the family or
Yeah.
the patient family as well as the patient.
I'll
So
just add
moving
on
on to the
if
next,
it is a
yes.
BMT, Poonam, I'll do it a little more in detail, knowing that I would very well be aware the family would, if it's a transplant, then of course they have already gone through the journey of chemotherapy, possibly radiation. They already know how grave the situation is and how likely the BMT is going to benefit the child. And I would be very clear in the conditioning regimen, etc., what I'm going to use. So I think I'll do it upfront and I like to involve as family members who can come up for the counseling sessions, do it, redo the counseling, and also try to keep the child or the adolescent in picture, or it's a young adult. So I like to do that in a much intensive way if it's a BMT that is in the pipeline.
All right. Thank you. Moving on to the next question. If you can move the slide, please. This is the same for Dr. Ruchira. So Dr. Rachna said when it comes to initial chemo, initial radiation, the treating team definitely discusses it, but they're a little bit careful about what they're talking to the family. But when it comes to BMT, they talk about it in detail. What about you, Dr. Ruchira? When a patient is due to start BMT, are all patients given all information regarding the impact on fertility before the start of the BMT? Dr. Ruchira? Are you there? Hello, Dr. Ruchira. Did we lose you?
We can move on to the next question.
Yes. And I think in any case, we did have Dr. Rachna clarify that when it comes to the BMT, then there is a much more detailed counseling session and a lot more information in full detail is imparted to the patients. What Dr. Rachna also said was very important to me, that when the patients first start treatment, maybe we are not focusing that much on all aspects of fertility. But before a BMT, by then the patient family has been through so much that they're much more ready to look at and understand the full implications of what's going to happen. And she, as a treating doctor, takes care of that.
Dr. Ruchira is here now.
Oh, Dr. Ruchira, thank you for coming back. I think we lost connectivity. So,
yeah. So the question that do we actually give this information? Well, obviously all transplanters will give that information. When we talk about complications, we talk about both short-term implications of bone marrow transplant as well as long-term implications. And fertility is a very big thing because a lot of families need to hear this, that their children can potentially become infertile after this life-saving procedure. So this is definitely a conversation that I think all transplanters will have. In fact, even our consent forms talk about these long-term impacts that happen. While Dr. Rachna was talking about including the patient as well, there's a little bit of social issues over there. Because would love them to be there to hear this conversation. But sometimes the parents feel that they're not comfortable talking about it there. But conversations around fertility being impacted post bone marrow transplant definitely happen.
Great, thank you. I'm going to come back to you with a question when we talk to Ria as well about how we talk to the children. But if we move on to the next question, and this is to Dr. Jayashree. So children and young adults are usually referred to the endocrinologist after a BMT. If we have inputs from the endocrinologist before starting the BMT with information on what are the potential medications, etc., can we do anything more to preserve fertility?
Thank you very much. I hope I'm audible.
Yes, Jayashree.
Yeah, thank you. Thank you, Poonam. So, like you rightly said, I think quite often people are referred to me after a BMT and after a diagnosis of, either an ovarian failure or a testicular failure is made. I am not quite sure if I would do anything differently, even if they are referred before starting the BMT, because I understand that the pressure of time is there. Potential medications that have been studied include usage of a GnRH analog, which is basically a medicine that shuts off the hormonal signals that go from the pituitary gland, which is present in near the brain, to the ovary, so that the ovaries are sort of put to sleep. That's a very simplistic way to think about it, but the ovaries are sort of put to sleep so that they're not affected. It's only actively dividing cells that get affected a lot by all the medications that are used during BMT. So if the ovaries or the testes are put to sleep and the actively dividing cells are sort of put into a state of rest, the thinking is that these cells would wake up once once the treatment is over and you stop the treatment. I think as Dr. Rachna mentioned in her talk at the start, the usage of hormonal therapy has not been very helpful. I think the most benefit in terms of fertility preservation comes from the methods that she had mentioned, which don't necessarily involve medical therapy per se. Medical therapy has been tried, but I would say that the evidence is very limited.
So, if I'm to understand what you said correctly, is that when we're talking about the medications, that's what you mean by the medical therapy, right? And you're saying that instead of getting into HRT and medical therapy, we should be looking at how are we going to preserve the fertility, and what Dr. Puneet actually talked about during the presentation, and we can ask her to come back to it when we ask her question. I think that is what you're saying needs to be done, right?
Sorry, Dr. Puneet is who I was thinking about. My
Yes.
my apologies.
Yes.
Yes, absolutely right, because that has much better data in terms of long-term outcomes as compared to using medications during the therapy process, the BMT
Okay.
process.
Okay.
Yeah.
Thank you. Thank you. So moving on to our next question. The question is to Dr. Puneet. So first off, Dr. Puneet, just to reiterate and just for the audience to understand that even during your presentation, you talked about the fact that if we're thinking of fertility is going to be compromised because of the BMT, and both Dr. Rachna and Dr. Richira said that we talk extensively with the patient or the patient family, as the case may be, about what will happen once the child, what is the type of BMT the patient is having, and how that might impact fertility. Then the next thing we are considering is that instead of looking at medications, we're looking at how we're going to preserve fertility. And in your presentation, you very nicely highlighted different ways in which this fertility can be preserved. But can you please tell us a little bit more about once we preserve sperms, how long do we need to, and how long can we, and also how successful is egg preservation?
So, thank you, Poonam, for putting on this question, because we now have what we called as a ART law, which is Assisted Reproductive Technology Law, which gives us a very clear recommendation on how long to freeze for. It says to freeze for 10 years in one go. We can do it. But it also mentions that we understand patients who are undergoing cancer treatment may use these frozen eggs and sperms even after 10 years of completion. So after 10 years, another request and a consent form has to be signed for extension of the frozen sperms and gametes, and we can freeze for another 10 years. So every 10 years, we'll have to renew our freezing as per our new law, which has come up.
And this is, what about the egg preservation? The same?
The same kind of implies for the egg preservation as well. And your question on how successful it is, we are in the era when there was a time when we used to say that egg preservation success is 30%, 33%. But now the frozen, if it is a good quality egg, 98% of the cases we get a good quality egg. So it is, I'm not talking about the success of getting a pregnancy from it, but kind of a success of the state in which we froze the egg getting back in the same condition. So that is pretty good with the current science. It is around 98, 99%. So they are useful techniques to consider before starting BMT.
So that's good to know, because when we first look at it and we say, okay, fertility is going to be compromised, but now to know that, okay, the technology has improved, the government has passed the relevant laws, we can preserve sperm for 10 years and then plus further, and likewise for the eggs. And technology has improved to be able to actually preserve sperm and preserve the eggs is very, very heartening to know. So moving to the next question, and this to Ria. So Ria, I just saw a film called A Copenhagen Love Story on Netflix, and I don't know if anybody's seen it, but it really is about the struggle of this woman who is trying to have a baby. And I mean, I'm sure there are stories and stories and stories. And I know it is as much and as difficult for men. We're in a patriarchal society. So if your boy or you yourself as the male in the family cannot actually have children later, it is a big issue. But because today is Women's Day, I'm going to ask you the question more from the women's side or from the girls' side, and say, this is really challenging for the parents as well as for the patient, right? So parents in the case of children, and then patients, right? So how can we help them? How can we help our families? How can we help the patient? How can we help the caregiver? Ria? Hello, Ria, are you there?
Me?
Yeah.
Yeah, can you hear me, ma'am?
Yes.
Yeah. Thank you for that question. I think one of the things that we kind of miss in this whole discussion about fertility after BMT is that we usually don't have children involved in this discussion. Most of the times, these discussions happen primarily between doctors and parents. But in my practice in the last few years, about it. Unfortunately, they're not included in these conversations, and there's a lot of, I think, with teenagers, there's a lot of hesitation to openly ask about questions regarding fertility and whether I'll be able to have children. So I think one of the best ways to do it is, to start a conversation around it and then address any gaps in information that a child might have. Of course, the information that we give them has to be age specific and kind of tailor made to their level of understanding. But it does help them in kind of being prepared. Um, and of course, sometimes they want to know options, how it's done, and things like that. So some children cope very well with information, and some just don't want to know. They just want to get through their treatment and not think about more kinds of treatment. So I think acknowledging what they need and the emotion that comes with it is one very significant way in which we can help them. Another thing that we could do is, if they want to know more, is to connect them with other people who have been through the process. Or we don't have many support groups that I know of, but if there is a group that has done this before and can help them from peer to, that is also very.
Sorry, I think you went on mute, Ria. Did you finish answering, Ria?
Yes, I'm done.
Yeah. So I think, broadly what you said and what I've understood is we don't talk to the little children. But if you're in those cases, you'd be talking to the parents, right? When it comes to teenagers, it's a little bit trickier because teenagers sometimes are hesitant, but I think they would worry. And so those conversations are important. And a third is if they're a young couple, right? If it's a young adult, then I think how you talk to them, what they need to know becomes even more important, because young parents or a young adult couple would really be thinking about having a family, right? So I think how we counsel them would depend a lot on which age it is, right? But this question also has another part to it. We're talking about cancer, but what about when the BMT is not for cancer? So I sort of think that if somebody in the family has cancer, then if the doctor is saying, look, this treatment can save your patient's life, and they may lose fertility, you might always say, okay, doesn't matter, we'll go ahead with it. But what about when it's not cancer? What happens then? Are you able to help us understand this piece as well? How can we help them?
Yeah, so I'm sorry I didn't address that. I think there is a lot of uncertainty and apprehension when it comes to this. So for example, at our center where we see a lot of benign hematological conditions, during the time of transplant, this is not usually a concern. But it's post-transplant, when children start to get better, a lot of parents or children start to think about issues like fertility. At the point of treatment, the primary focus is on trying to get the child well and transfusion free, or whatever the goal is. And then we see this usually come up at a later point in our survivorship clinic. So for example, when our kids have grown up and they're getting ready for marriage and things like that, and it's unclear. So from what I understand, whether you're fertile or infertile is not black or white. Many times they are told that there is a risk, but how much is the risk? Is my particular child capable of conception or not, is something that parents are worried about at that point. And that's a very difficult question to answer. And also, it's difficult to deal with the uncertainty that it may not happen. So especially in Indian households, we have a lot of families that bring concerns to us about, will my daughter be able to get married? Because if she can't conceive, no one's going to want to get married to her. And these are very, very real concerns. So a lot of times it's kind of, in terms of psychological intervention, what we do is more about coping skills training, helping to deal with uncertainty, those kind of interventions, so that you're more equipped to deal with a problem when it does arise.
Fair enough. Though I also think that psychoeducation would be important, which is to actually give them the information and say, keep it for when you want to address it later, right? So at least they know. And to be able to give them the option of, you could do this now and then worry about it when it comes up, right? So psychoeducation
Absolutely.
would also play a part, correct? Yeah. So shall we move on to the next question?
Absolutely.
Yeah. So back to Dr. Rachna. So Dr. Rachna, you've had so much experience following up children after chemo, after radiotherapy, after the BMTs, etc. So have you observed a difference? Do you see that patients after BMT, is the side effects profile different? And to me, it's a very intriguing question because a lot of the work also that we seem to be doing is around side effects for chemo and radiation. But this is the first time I myself am looking at, okay, what happens after BMT? What are those side effects?
Yes, well, thank you for this question. So I'll like to just answer this. I was just reading through it. Maybe I'll take it up in a way that they can be acute and late effects because they say side effects. So there is a difference. So anything broadly, I should say that any of these effects are going to be exacerbated once it comes to a BMT. But nevertheless, for acute, like I will say, you will have simple things like maybe nausea, vomiting, mucositis, fever, febrile neutropenia, some pneumonia, with a chemotherapy or radiation-induced some complications, dermatitis, nausea, fatigue, etc. They are fairly mild and we are able to tackle these acute side effects. But even when you come to acute side effects for a BMT, they are far more intense, be it nutrition, be it the nausea, the vomiting, the mucositis, the acute GVHD, which may come up not immediately, but then acute GVHD does create a lot of problem. So these all conditions do have a, besides the acute social aspects also, or the acute aspects. In the late effects, it also depends. The late effects, if you come to, that is again what you said, that is an area of interest and bothers all of us. So in the late effect also, I would feel that there are a lot of determinants to it. Dr. Puneet and Dr. Puneet has already touched on many aspects, but then they will add to it. But what I was just thinking while reading this question was that age may be an important determinant, then of the child. Then what conditioning have we used? Whether we have used a chemotherapy based or whether we've used a total body radiation. So all these things, what has been the previous functional status of the child, what chemotherapy have we or radiation have we used prior to considering a transplant. So there are a lot of determinants to, the occurrence of the late effects. They do have some vary even in the acute phase of the side effects that we have. In late effects, again, we have lot of, if you look at the late effects, then again, GVHD, again, chronic GVHD is a major concern. Then our fertility, this is a big concern. What type of, even if you do, and also the type of transplant that we are doing, whether it is a autologous or a allogenic, there is a lot of difference in the acute and the late effects that we face with these. Then, if you look at late effects, what I just mentioned was one was your GVHD. Then you have cognition. Neurocognition is a big concern. The cognitive deficits, the psychosocial deficits, and fertility is another big concern. Besides the other concerns of metabolic syndrome, all those that will come up. So I would say that uh, there is a difference. With the chemotherapy and radiation, they are very acute, can be tackled quite well. There are a lot of determinants to the occurrence of these acute and late effects when a BMT comes into picture. Some are just a progression of the acute to the late, psychosocial, GVHD, nutrition concerns, etc. But all these concerns of cognitive deficit, fertility dysfunction, all these GVHD, all are far more enhanced when they come to a BMT. But then they are, in today's era, I think they can be tackled in a big way. I hope I've been able to.
Yes. Thank you, Dr. Darshana. That was very comprehensive, and a lot of further questions that come to mind. But I also want to keep an eye on the time. So let's take the next question, and perhaps between you and Dr. Ruchira, you can answer one question I have in mind. So, Dr. Ruchira, what are the advances in the BMT field which can protect fertility in young patients undergoing BMT? And are there less toxic chemo and radiotherapy methods that we can use?
So thanks, Poonam, for that question. So like Dr. Rachna mentioned, that total body radiation is a big factor when we're thinking about infertility. And so dosing and fractionating the therapy would often make a difference there. In terms of chemotherapy, we know alkylating agents like cyclophosphamide or even other agents like busulfan are known to cause infertility. And therefore, now the trend is to move towards what is called a reduced toxicity regimen, which will like using a drug other than busulfan which does not have infertility as a side effect. And we tend to use that more, especially in our non-malignant cases. We tend to use that more so that we can hope that this child will not become infertile. There are also talks about myeloablative conditioning being more responsible for infertility. So if the condition permits, we will use a reduced intensity conditioning regimen if we think that that is safe. If we think that that's not safe, then obviously we will use myeloablative because we want the transplant to be successful. So, but there are these less toxic chemotherapy and radiotherapy protocols that are available, and we can always look at discussing this with the family, discussing the pros and the cons, and then choosing one which will benefit the patient in terms of treating his disease, yet at the same time reducing the long-term side effects as well.
Thank you. So just a quick question which it struck me. Is there a difference between what will happen during auto, allo, haplo, different types of BMTs when it comes to affecting fertility, or is it the same? Because you mentioned that, if it is TBI or it is depending on what drugs
So
you
it's
use.
not the type of transplant, auto, yeah. It's not the auto or the allo, it's the drugs that we use. So like busulfan is used both for autologous as well as allogenic transplants. And busulfan is a known agent to destroy your sperms and eggs. So if in those cases, if we can move towards tiosulfan, then that's a better option. So it doesn't matter on whether it's an allo or an auto or it's a haplo, it's the drugs that make a difference. And then again, we know that for some leukemias, radiation is actually beneficial. So total body radiation is known to cause infertility. So we know that if we can do that, but then at the same time, do we think that in some, not for blood cancers, but in some other cancers, do we think that testicular shielding might help? Then in those cases, we would offer testicular shielding to those patients as well. So those are things that we can talk about. Yeah. Or
And you
if
use,
doing
yeah,
just
sorry.
abdominal radiation, if you're doing just abdominal radiation, so like Dr. Puneet mentioned, whether we can transposition the ovaries before the transplant and the radiation happens, then that is something that we should be looking at as well.
Okay. So essentially, it's either the radiation or the total body irradiation or the drugs, and that basically determines it. And we talked about how we can preserve fertility. And in this case, you also talked about, other than fertility preservation, also something to do with moving the ovaries aside. What was the term that is used?
Transposition.
Yes, transposition of the ovaries, or actually testicular shields for the boys or men, right? Okay, so let's move to the next question. Can we move to the next question, please? Yes, and this is back to Dr. Jayashree. So, Dr. Jayashree, if a patient is receiving high-dose chemotherapy or radiotherapy during BMT, can she have the hormone medications to help stop her periods?
Yeah, absolutely, yes, that can be done. We either use hormonal medications like estrogen, progesterone, what is similar to what is found in the contraceptive pill, that type of tablets we can use to stop the periods. Obviously, this would depend upon the age and whether the children have started, what process, what part of their pubertal process they are. Have they started getting their periods? Are they having regular periods? What is happening? If it is someone with very regular periods and it looks like the therapy would need to be prolonged, then a better option, another option, I wouldn't say necessarily say it's a better option. Another option would be the medicine that I was mentioning earlier, which is a medicine which shuts off one of the hormones which comes from the pituitary gland. It's given as an injection once in a month, and that helps to stop the periods. Now, I have to ask, the pediatric oncologist here, because I have not been referred people specifically for this indication. So I'm not quite sure. Unless they develop bleeding problems, they're not referred to me for this issue. Or, for example, they have problems with, say, a drop in their platelet count, and because of that, they're having bleeding issues. Something like that is when we generally would tend to get involved. Is that right, Dr. Ruchira, Dr. Rachna? I think you're sort of in a, yeah.
So, Dr. Jayashree, if you're asking me, so we would want, because once we know that if it's particularly if it's pubertal girl child, there's already a lot of Poonam, I can take this in between.
Please, Dr. Rachna, the question is to you. Yes.
Dr. Jayashree, we do come across these situations when they are having acute leukemias, their counts are going to be very low, and then platelets are going to be very low. They will have excessive bleeding during their menstrual cycle, which is an added stress and a source of blood loss. So we temporarily do want to resort, at least give respite on this front. So we are now, earlier, if you ask me also, 3 years down the line, I was not even giving so much of attention, or maybe was not aware so much. But in today's era, when an adolescent girl child comes to us, we would consider this upfront and would use maybe your GnRH analogs, etc., to take care of this for temporary cessation, so that we can preserve the whatever you all have discussed very well, that preserve the whatever ova, etc., the follicles that you can preserve. We do resort to that.
Thank you, Dr. Rachna, and thank you, Dr. Jayashree. Can we move to the next question? This is to Dr. Puneet, and I'm not even going to try and say the word. It's complicated for me, and I'll probably mispronounce it. But what is ovariopexy, and how does it help a patient during radiotherapy?
So I think ovariopexy is the same thing what we had just discussed, moving the ovaries out of the way, right? So because the way they are situated is what we call as an area pelvic fossa, in the pelvic, kind of a lower part of the body, the abdomen, where they're situated. So if a female is undergoing radiotherapy, then obviously moving the ovaries out of the way prevents the radiation to be transmitted to the ovaries. It may not work very well if the radiation is planned for total body, because wherever we will move, it is not going to work. But if the radiation is planned for the pelvic area where the ovaries are situated, moving them to the upper abdomen, we generally we put below the diaphragm, which is kind of a region between the lungs and the abdomen. It helps to preserve ovarian function a bit. But I think total body irradiation, it is not going to work even if you do it.
And what about those testicular shields that you talked about? If it is total body radiation, will they work?
So again, the ovarian shielding, testicular shielding, it is just like making a placebo effect. You can still put it, but they may not offer much protection. Yeah.
Thank you. Next question, please. This is back to Ria. So when we counsel families for BMT, obviously there's a lot of anxiety regarding puberty and fertility, right? And you did well on this in your earlier response as well. But what are some of the practical areas to address the issue?
Thank you, Poonam ma'am, for that question. So usually in pre-BMT counseling, once the treating team addresses the issues around puberty and fertility, if the parent or the child has concerns about it, like you said, we psychoeducate, and we kind of reassure or reiterate the fact that these are uncertain changes. They are not always 100%. So kind of managing the anxiety around that is actually the most challenging bit that we face, because preservation is expensive sometimes in our context. So many parents have a question as to should we invest money to do this? Is it 100? Is it going to happen 100%, etc., etc.? So I think it's multifactorial. The anxiety is not just about fertility, but it's about multiple other things that are connected to it. And we primarily work on trying to understand and cater to all those aspects. And if we are able to do that, usually we're able to address the anxiety and the issues that come with it.
I think, Ria, that's about correct. And earlier, before we did the panel discussion, we were talking about it, all of us. And we were talking about, when do you tell parents? Which are the parents you tell? And as a patient advocate, I say it's my right to know. And it's the right of the family to know. But today, I liked what Dr. Rachna said that, maybe when they start upfront treatment, your thought process can be a little bit different. But by the time you get to a BMT, then I think it is really the right of the family to know. And therefore, from the practical point of view, we should be looking at addressing fully and educating the family fully. You talked about maybe not telling little children. Perhaps that's okay because it must be difficult to explain it to a little child. But I would think from a teenager upward, we do need to rope them into the conversation and at least help them understand at their level. And then talking about the practical issues, those practical issues are really to do with social issues, right? What will happen? How can I preserve? Where can I preserve? What will it cost? Are the facilities available? And for me, that's the biggest thing that has happened in the last 20 years, that things have changed. So much more is available that it's important to share the information with the family, no matter where they come from. That, okay, this is how you can preserve fertility, and this is what will happen afterwards. This is the way I look at it. But let's see if we
Absolutely.
have
I think
another
just
question.
to
Yeah,
just to
sorry, Ria.
add very
Yes.
quickly,
Yeah.
in kind of malignant conditions, another problem we face is in the kind of burden of time, especially for girls, like Puneet ma'am said earlier. So sometimes even though parents might want to do it, there may be kind of an urgency to begin treatment and kind of put this on hold for some time.
So I think we're out of time, is what Dr. Revati has pointed out. And therefore, if we can very quickly ask all our panelists if you have just one takeaway message or one important message to share with our audience and to share with, patient support group members, right? I think we can stop this question from the organizers so that we just go through one point and we'll start with Dr. Rachna. Dr. Rachna, one final point or one takeaway message?
I would just say that in today's era, there needs to be a high a degree of, I think there's a need for sensitization for all the treating team as well towards the deficits of towards reproductive deficits that can occur. And we need to be, and as a treating team, I think all of us need to be aware of what can, occur as acute or, in the later part of treatment. And I agree with you, Poonam, that we should come down to the maybe socioeconomic level of the parent, because we know that we'll be dealing with a very a profile of patients, that some information should be given to the family. So I feel that sensitization and as treating team also we should be aware of the deficits that can occur, and these often can be tackled. And we moved far ahead, and I think as Puneet has already said that there are a lot of opportunities for preserving, and I think financial constraints are there, but I think they can be tackled in the times to come. They will decrease only. So I think that is what I would like to say.
Thank you, Dr. Rachna. Dr. Ruchira, takeaway message, final point? Yes.
Yeah. So I think the conversation needs to start at the time of diagnosis itself. When you come to a bone marrow transplant, you've already received chemotherapy. And so in some cases, it might be too late to offer any treatment or any tissue preservation or even sperm preservation at that stage. Time always becomes a challenge for us in most cases. What I really feel is personally that some people or some families harp on the need that their child should be fertile and they should bear children. And I think there needs to be a very big shift from that. It's important to save a life. If the child lives to be old enough to be able to produce children, maybe that's his destiny. But at the moment, what we're trying to do is to try and save the child's life so that he grows to be an adult at that stage. And also, since research is happening so much, for all you know, that what we may not be able to offer today, in 20 years' time, we would have something that we can offer to somebody who's not had any tissue preservation or anything done at that time. And there are more than one method of bearing children or having a family even today. You can't have an IVF, you could have adopted child. So the very fact that I think that mentality and that stigma needs to kind of move a little bit.
Yeah. And I think, therefore, the role of the multidisciplinary team, the psychologist being part of it to talk the family through it rather than saying that, we won't tell because perhaps they will not take the treatment. Your point is very valid that life is more important at that stage, but nevertheless, right to the patient to fully understand requires the support of all of us. So moving to Dr. Jayashree. Dr. Jayashree, your final takeaway message.
I don't think I have anything to add, honestly. You can move on. I think Dr. Rachna, Dr. Ruchira said all that I wanted to say, honestly.
Thank you so much. And thank you for being with us today, Dr. Jayashree. So we'll go to Ria and then go to Dr. Puneet because she's the fertility expert. Ria.
Thank you, Dr. Poonam ma'am. So I think my only takeaway message is that in terms of psychological and social support, it has to be ongoing because issues arise. It's not kind of a one-time point thing. So continuing support during, after, and during survivorship is very crucial because issues keep evolving. So being in touch with your treating team, all of us, not just the primary physician, but also the others, could significantly help in your journey, to make things easier.
Yeah, and I think the financial and the psychological support become a very key part of it, especially post BMT when we're looking at, okay, what can we do with it? How do survivors integrate? How do they cope with it? And maybe when a survivor grows up, they don't have the information from when they were treated. So that kind of support becomes very, very important. So Dr. Paneet, back to you. You started our session with a wonderful presentation, and we want to know from you.
So I think I'm thankful that we are discussing in this forum And the primary care providers, Dr. Rachna, Dr. Ruchira, and all believe that it should be discussed. I think that's a win-win for our patients, because that is the quality of care. If they primary care physicians agree to it, then only it will be discussed, and then only we come into picture. So I'm very thankful for this forum, and I think I'm seeing a way forward, because I have seen a point where we were just talking about it and it was just kind of a given a disregard. But I think everybody talking about it, I think it's very good for our patients. So thank you so much for this forum and the opportunity to have us all together.
Yeah, and I'd like to thank ISBMT for that. Thank you very much for organizing this today, because it means that we're thinking about this is important, and it's time that we talked about it to families, to patients, to caregivers, and also try to find solutions. Try to find solutions that belong to today's world. We don't need to not tell families and patients, because now we have solutions to offer, both for the preservation piece as well as for fertility treatments afterwards. And Dr. Puneet was telling me earlier today that that is not just in big cities. More and more, you can go to the smaller cities and find these options. So the more we have the information, the more we educate, the more we're able to help families. Dr. Revati, thank you very much for having us today. And Dr. Silki Jain, thank you for hand holding us, as well as the organizers for doing this very, very enlightening panel discussion. Thank you.
Thank you,
happy
Poonam. That
Women's Day
was
to
an
everyone.
amazing discussion. Thank you to all of you. And I'm going to hand over the podium to Suman, who's our nurse leader and part of the patient support group, to deliver the vote of thanks. Over to you, please, Suman.
Thank you, ma'am. Happy Women's Day to all. To begin with, I really thank Dr. Puneet Arora for such insightful talk. You made the topic so simple to understand all. Thanks to Poonam Bagay ma'am for moderating the panel discussion. Thanks to all panel members, Ms. Riya Darwala, Dr. Rachana Seth, Dr. Ruchira Mishra, Dr. Jayashree Gopal, for answering all the important questions. Thank you for giving your valuable times for this session. Here I would like to thank Dr. Shashikant Apte, Dr. Tapan Saikia, Dr. Revati ma'am for mentoring throughout the program. Thanks to all for the patient support group members, and many thanks to all the participants today. Hope to see you again for next month, and thank you, ma'am. So next topic will be for the next month will be the chronic myeloid leukemia, and it is on the 12th April. Timing is the 3 p.m. to 4 p.m. Thank you, ma'am, and have a good day to all.
Thank you.
Thank you. Thank you very much.
Thank you all.